stool stuck in the rectum. What is it and what to do? Have you ever found yourself in the bathroom facing a frustrating 30 or even 60 minutes with an urgent sensation that simply refuses to materialize into any actual bowel movement? You can feel the pressure, the undeniable discomfort, yet your body remains stubbornly unresponsive. In these moments, resignation often sets in, leading you to retreat, admitting defeat with a promise to yourself to try again later. But as later arrives, the same disheartening scenario repeats, leaving you feeling bewildered and concerned. If this experience resonates deeply with you, it's crucial to understand that this is likely more than just ordinary constipation, and simplistic home remedies may not be enough to address the underlying issue. I am Dr. Michael Adeyemi, and in this comprehensive discussion, I aim to demystify what truly occurs when stool becomes lodged within the rectum. We will delve into why this condition can be significantly more serious, particularly for individuals over the age of 60, and I will provide a detailed, step-by-step guide on precisely what actions you should take. Our exploration will be grounded in real anatomy and realistic solutions, acknowledging that while the topic may be uncomfortable, your health and well-being must always take precedence. If any part of this scenario feels even remotely familiar, please consider typing "yes" in the comments section. By doing so, you will not only find solidarity with others experiencing similar silent struggles, but also help more people discover this vital information. To truly grasp what is happening within your body, let me paint a vivid picture, not from a sterile textbook, but from the reality I witness. Imagine, if you will, a long, meandering river that has, for years, flowed with a consistent, healthy rhythm. The water moves steadily, nourishing everything downstream. Now picture this. Over the course of a week, with imperceptible slowness, the river's flow begins to diminish. Perhaps a prolonged, dry spell has reduced the water volume, or maybe a gradual accumulation of debris has started to clog a narrower section. The river doesn't cease its flow abruptly, rather it decelerates inch by inch, day by day. Eventually, this debris compacts so tightly at a specific bend that the water can no longer pass through. This analogy perfectly illustrates what happens within your colon. The medical term for this phenomenon is fecal impaction, but I believe this clinical label can inadvertently lead people to underestimate the gravity of the situation. In plain terms, your large intestine, your colon, functions as a muscular tube designed to propel waste material towards its exit while simultaneously reabsorbing water from that waste. Under normal, healthy conditions, this is a remarkably efficient and largely automatic process. Waste moves, water is absorbed, and the resulting stool remains soft and easy to pass. However, aging introduces significant changes into this intricate system, and this is a vital point that every individual over 60 should internalize. As we advance in age, several physiological shifts occur within the digestive system. The muscular contractions responsible for moving waste through the colon, a process known as peristalsis, naturally slow down. The intricate network of nerve signals that orchestrates these contractions becomes less efficient. Furthermore, the sensation of thirst tends to diminish, leading many older adults to experience chronic, mild dehydration without even recognizing it. Adding to this complexity are the myriad medications commonly prescribed to older adults. Drugs for blood pressure, iron supplements, calcium channel blockers, and certain pain relievers are notorious for slowing bowel motility as a side effect. When you combine these factors, reduced peristalsis, less efficient nerve signaling, decreased hydration, and the impact of medications, you create an optimal internal environment for stool to linger too long in the colon. As it sits in the lower segments, it loses excessive moisture, transforming from a soft, manageable consistency into something hard, dry, and, in essence, immovable. By the time this mass has resided for 5, 6, or even 7 days without complete expulsion, it has dehydrated into a dense, solid mass. When this unyielding mass finally reaches the rectum, the final storage area before elimination, and it simply cannot pass through the narrow outlet, you have a fecal impaction. The pressure you feel is real. The exhaustion from futile straining is a genuine consequence, and the fear that something is seriously amiss is entirely justified, because indeed, something is seriously amiss. If you are gaining valuable insight from this information, please take a moment to hit the like button. In this second segment, we will explore why fecal impaction is far more dangerous than most people realize. I want to dedicate substantial time to this aspect because it is precisely this part of the condition that catches individuals completely off guard. People often associate the term constipation with inconvenience, but not necessarily danger. However, a fecal impaction is neither merely inconvenient nor harmless. Let me guide you through the cascade of internal events that begin to unfold when a large, hardened mass becomes lodged in the rectum for an extended period. The initial concern is structural pressure. Your rectum, while elastic, is not designed to accommodate a cemented, dehydrated mass indefinitely. When it is chronically overstretched beyond its normal capacity, the blood supply to the delicate tissues lining its walls becomes compromised. These vital cells require a constant influx of oxygen and nutrients carried by the blood. When this circulation is significantly reduced or cut off, the cells begin to suffer. In severe or prolonged cases, this can lead to tissue injury that necessitates medical intervention for repair. Now, here is a detail that genuinely surprises most individuals when I explain it in a clinical setting. Your rectum and your urinary bladder are in close proximity, sharing the confined space of the pelvis, separated only by a thin, fibrous wall. When your rectum is packed with a solid, rigid mass and distended far beyond its usual limits, it exerts physical pressure against your bladder. This pressure is often more pronounced in women due to specific anatomical considerations. Consequently, patients may experience a sudden and baffling difficulty in urinating. They might feel a persistent urge to void but only pass a few painful drops, or in more severe instances, be unable to urinate at all. I have encountered patients who arrived at my clinic with the firm conviction that they had developed a sudden bladder infection, when in reality, the underlying cause was a rectal impaction pressing on the bladder from behind. Once the impaction is addressed, these urinary symptoms typically resolve completely. However, the complications do not end there. There is one more symptom that I must specifically warn you about, as it is so profoundly confusing that it can tragically lead individuals to exacerbate their condition. This symptom is known as overflow incontinence, and it presents externally in a manner that closely resembles diarrhea. Here's what transpires. The solid mass effectively blocks the primary exit route, yet your intestines continue to produce liquid waste higher up in the digestive tract. This liquid has no alternative but to seep around the edges of the hardened blockage, much like water finding a crack in a dam, and leaks out unpredictably. Upon observing this liquid, individuals mistakenly conclude, "I clearly do not have a blockage. I am experiencing diarrhea." Tragically, some may then proceed to the pharmacy and purchase over-the-counter anti-diarrheal medications to halt this perceived symptom. This action represents one of the most dangerous mistakes one can make in such a situation. Anti-diarrheal medications work by inhibiting the muscular contractions of your intestines. By taking these medications, you are effectively paralyzing the very mechanisms your body is attempting to employ to circumvent the blockage. This action will only serve to further cement the impaction in place, making it even more deeply lodged. I strongly recommend that you save this video for future reference. While you may not need it today, if you or a loved one ever face this situation, having this detailed, step-by-step guide could prove to be invaluable, potentially averting a medical emergency. If you are experiencing what appears to be diarrhea in conjunction with days of feeling unable to achieve complete bowel evacuation, please seriously consider the possibility that it is overflow incontinence, not genuine diarrhea. And under no circumstances should you self-medicate this symptom without first consulting a healthcare professional. In the third segment, we will examine why seniors are at a dramatically higher risk for fecal impaction. I want to address my older adult viewers directly. as the statistics surrounding this issue are sobering and rarely discussed in mainstream health content. Fecal impaction is not an evenly distributed condition across the population. It disproportionately affects individuals over the age of 65, with the risk escalating significantly with each subsequent decade of life. In nursing home and long-term care settings, some studies indicate that fecal impaction affects as many as 40% of residents, rendering it one of the most common gastrointestinal emergencies encountered in geriatric medicine. Yet, it also remains one of the most preventable conditions when individuals understand the factors that contribute to the risk. Let me outline the primary risk factors that are particularly relevant to older adults. Reduced mobility plays an enormous role. When we engage in physical activity, whether it's walking, exercising, or even simply standing and performing light household chores, we are mechanically stimulating our digestive system. The simple act of walking creates gentle rhythmic pressure within the abdomen that aids in keeping intestinal contents moving. When mobility decreases due to conditions like arthritis, recent surgery, falls, or any other cause, this vital mechanical stimulation is lost, leading to a slowdown in colonic function. Dietary changes are another significant factor. Many older adults experience a decrease in appetite, leading them to consume smaller meals. They may also reduce their intake of fiber and, crucially, their water consumption. This reduced fluid intake is partly due to the diminished reliability of the thirst mechanism with age. All of these dietary modifications result in stool that is less bulky and less moist, making it more susceptible to hardening. Then there are the medications. This is a critical conversation that I strongly encourage every person over the age of 60 to have with their doctor or pharmacist. A considerable number of the most commonly prescribed medications for older adults list constipation as a direct side effect. This includes opioid pain relievers, certain antidepressants, antihistamines, iron supplements, high-dose calcium supplements, and diuretics that promote fluid loss. If you are taking multiple medications, as many of my older patients are, the cumulative constipating effect can be substantial. Finally, we must address the issue of suppression. Many older adults were raised in an era where discussing bowel habits was deeply taboo. Consequently, when they experience the urge to defecate but find themselves away from home or in an inconvenient situation, they suppress the urge. They wait. Repeatedly suppressing this natural signal over months and years can retrain the rectum to become less sensitive to the urge, making it less frequent and less urgent, and thus allowing waste to remain in the colon for longer periods. Understanding your own unique risk factors is the foundational step towards preventing this situation from recurring. Before we move on to the exact step-by-step solution, please ensure you are in a location where you can fully concentrate, as what I am about to explain could help you avoid a trip to the emergency room. In segment 4, we will discuss the emergency action protocol. You now have a comprehensive understanding of what is happening and why it occurs. Now, let's address what to do if you find yourself in the midst of this situation right now. The very first instruction I want to give you, and I want to ensure you hear this clearly, is this: stop straining. I understand it feels instinctive. Your body is likely screaming at you to push harder, to try a different angle. However, physiologically, a solid, dehydrated impaction does not respond to pressure from above in the same way that normal stool does. It is simply too rigid. In fact, excessive straining can significantly increase the risk of developing hemorrhoids, anal fissures, or even a rare but serious condition known as Valsalva syncope, a sudden drop in blood pressure caused by extreme straining, which can lead to fainting. For older adults with existing cardiovascular conditions, aggressive straining can also place dangerous pressure on the heart. So please stop straining, take a breath, and let's work through this systematically. Step 1 involves glycerin suppositories. You can purchase adult glycerin suppositories at any pharmacy without a prescription. For a hardened impaction in an adult, a single suppository is often insufficient. In consultation with a healthcare provider or following established clinical guidance, many practitioners recommend using 2 to 3 adult-strength suppositories simultaneously for an established impaction. Here is the precise method for their administration. Lie on your left side, not on your back, or in an upright sitting position. but on your left side. This posture aligns with your anatomy, specifically taking advantage of the natural curve of the sigmoid colon and rectum to direct the medication effectively towards the impacted mass. Before insertion, apply a generous amount of water-based lubricant to each suppository. Do not skip this crucial step. Surrounding rectal tissue is likely already irritated and sensitive, so lubrication will not only enhance comfort, but also improve the effectiveness of the suppository. Insert the suppositories gently and to their full depth. Breathe slowly and steadily, and this is where most people falter. Do not move. Remain on your side, stay still, and wait for a minimum of 30 to 45 minutes. If necessary, set a timer. Glycerin works by drawing moisture into the stool from the surrounding tissues through osmosis and by lubricating the rectal walls. It requires time to soften the outer layer of the mass before any expulsion can occur. If you rush to the toilet after only 10 minutes, you are very likely to simply expel the suppository itself, leaving the impaction precisely where it is. Step 2 is the second attempt. If, after that initial round, nothing significant has passed, do not despair. And again, do not immediately resort to forceful pushing. Gently get up and walk slowly around your home for 15 to 20 minutes. Gentle movement is key as it stimulates peristalsis. Then, lie back down and repeat the entire process, allowing for another full 30 to 45-minute window. This second round of glycerin is often what is needed to soften not just the outer layer, but to penetrate further into the mass, allowing it to begin breaking down. Step 3 is the warm water retention enema. If 2 rounds of suppositories have not yielded results, the next step, prior to seeking emergency medical care, is to administer a warm water or saline retention enema. These are readily available over the counter, often sold under brands like Fleet or similar products. Follow the instructions provided with the product carefully. Lie on your left side, administer the fluid slowly, and once again, the goal is to hold it in. Do not rush to expel it. The objective is to introduce enough fluid and warmth to further hydrate and loosen the impaction from above. Step 4 involves emergency medical care. If all your at-home attempts have been thorough, and I want to emphasize the word thorough as patience is truly paramount in this situation, and have been unsuccessful, then it is time to proceed to an urgent care facility or emergency room. This is not an admission of defeat. Rather, it is a rational and informed medical decision. At the hospital, the clinical team has access to high-volume therapeutic enemas containing medicated solutions that can penetrate much deeper into the colon than anything available over the counter. They also possess imaging capabilities to accurately assess the extent of the impaction and to determine if it extends beyond the rectum into the sigmoid colon or further. In instances where clinical enemas are insufficient, which does occur, particularly with long-standing impactions, a specialist will perform what is known as manual disimpaction. I want to be direct with you about this procedure. It is precisely what it sounds like. A physician, wearing protective gloves and utilizing substantial lubrication, will manually break up and remove the impacted mass piece by piece, given that the surrounding rectal tissue is likely to be extremely inflamed and sensitive by this stage. This procedure is typically performed under sedation or regional anesthesia. It is undoubtedly uncomfortable to contemplate, but it is a safe, routinely performed clinical procedure, and the relief that patients report immediately afterward is, without exception, extraordinary. In segment 5, we will discuss recovery and what happens next. Once the impaction has been successfully cleared, whether through at-home efforts or with medical assistance, your body will enter a brief recovery phase that requires your attention and care. For the initial 24 to 48 hours, the rectal tissue will likely be irritated, swollen, and sensitive. You may experience some discomfort, light spotting, or a feeling of rawness. This is expected and will gradually resolve with time. A warm sitz bath, which involves soaking the lower portion of your body in warm water for 10 to 15 minutes, 2 to 3 times a day, can provide significant relief and promote tissue healing. For the first few days following the impaction, your diet should focus on easily digestible, soft, fiber-containing foods. Think along the lines of oatmeal, cooked vegetables, ripe bananas, and soups with soft vegetables. It is essential to avoid anything that is dry, tough, or lacking in moisture. Continue to drink water consistently and deliberately throughout the day, even if you do not feel particularly thirsty. This is also an opportune moment, while the memory of this challenging experience is still fresh, to schedule some important appointments. Book a visit with your primary care physician to review your current medication list, specifically looking for any drugs that might have constipating side effects. If constipation has been a recurring pattern for you, request a referral to a gastroenterologist who can conduct a more formal evaluation of your colonic motility. Furthermore, if you have not undergone a colonoscopy within the recommended time frame, this is an important juncture to ensure that any potential structural causes, such as a narrowing of the colon or a growth-affecting passage, have been thoroughly investigated. Please share your current health condition along with your age in the comments section. I will personally reply to every single comment. If you have found this information helpful, please press the like button and subscribe to the channel. Finally, in segment 6, we will address long-term prevention, which is the ultimate foundation for good health. I want to conclude today's discussion with the most crucial piece of advice I can offer. Everything we have discussed up to this point has focused on crisis management, and while critically necessary, crisis management should never be the ultimate goal. The true objective is to cultivate a lifestyle that prevents such a crisis from ever occurring again. The long-term prevention of fecal impaction in older adults rests on 4 fundamental pillars. Pillar 1 is hydration. Water is by far the single most powerful tool your colon possesses for maintaining soft, pliable waste. Aim to consume at least 6 to 8 glasses of water per day. If plain water feels unappealing, warm herbal teas, broth-based soups, and fruits and vegetables with high water content can all contribute to your daily fluid intake. Set alarms if necessary. Make it a deliberate and consistent habit. Pillar 2 is movement. You do not need to embark on a marathon training program. A daily walk of 20 to 30 minutes is genuinely one of the most impactful actions you can take for your digestive health. If walking presents difficulties, even gentle chair exercises or swimming can help maintain intestinal motility. Pillar 3 is dietary consistency. Soluble fiber found in foods such as oats, fruits, legumes, and cooked vegetables plays a vital role in adding bulk to stool and retaining moisture. If you are not accustomed to a high-fiber diet, introduce it gradually to avoid potential gas and bloating. Furthermore, establishing a consistent mealtime routine helps your intestines develop a natural rhythm. Pillar 4 is scheduled bathroom time. The gastrocolic reflex, the natural signal your colon sends to prepare for a bowel movement after eating, is typically strongest in the morning, often within 30 to 60 minutes of breakfast. Make it a habit to sit on the toilet at this time each morning, even if you do not feel an immediate urge. Using a small footstool to elevate your feet slightly can place your body in a physiologically optimal position for elimination. Dedicate 5 to 10 minutes to this ritual without rushing or straining. Over time, your body will relearn this natural rhythm. I strongly advise against relying on stimulant laxatives as your long-term solution. I understand their appeal. They work, they are readily accessible, and they provide swift relief. However, the long-term, daily use of stimulant laxatives can train your colon to become dependent on artificial stimulation. When you cease using them, the colon may have largely forgotten how to initiate movement on its own. This condition is known as cathartic colon, and it is a well-documented consequence of prolonged overuse of stimulant laxatives. Far safer alternatives exist, such as osmotic agents, stool softeners, and fiber supplements, which your doctor can recommend as part of a sustainable and healthy plan. I realize this has been an extensive conversation, and I understand that some of the information may have been difficult to absorb. However, I firmly believe that the most significant health discussions are often those that feel the most uncomfortable. You deserve to understand what is happening within your own body. You deserve a clear plan of action when something goes wrong, and you deserve to know that whatever you are experiencing, you do not have to navigate it alone, and you certainly should not feel embarrassed about it. If you have found today's video genuinely beneficial, I kindly ask you to do one thing: share it. Send it to a family member, a friend, a neighbor, or anyone in your life who might be silently struggling with this issue and is hesitant to speak about it. This video could be precisely the resource they have been seeking but did not know how to ask for. Please click the like button if this content has been helpful. Subscribe to the channel so you don't miss our upcoming videos on digestive health, longevity, and taking proactive control of your health as you age. Take care of yourselves, drink your water, move your body, and I will see you in the next video.